take a couple of minutes to talk about keratoconus. We can't have a cornea lecture without talking about keratoconus. It's one of those things that if you are in practice as an ophthalmologist, you will see this. This is common. So its incidence is about 50 per 100,000 individuals. Keratoconus is characterized by central or paracentral corneal thinning and bulging. It is a progressive condition that generally begins to manifest in early adolescence. The heredity pattern of keratoconus is currently unknown, but certainly family members with this disease is a risk factor. Do note that family can have subclinical disease, so when you ask your patients, they may have had family members who had poor vision or wore glasses, but not necessarily everyone in the family might have been formally diagnosed or had a penetrating keratoplasty to treat the condition. Nearly all cases of keratoconus are bilateral, but note that the severity of the disease in the two eyes can be vastly asymmetric. So it's not uncommon for me to see patients in my practice with keratoconus who are good eye, 20/30, 20/40, a bit myopic with some cylinder, and the bad eye is count fingers with tons of cylinder and astigmatism. So note that though bilateral, this condition can be very asymmetric between two eyes in a single patient. Keratoconus is associated with Down syndrome, Marfan syndrome, atopy, mitral valve prolapse, Leber's congenital hereditary optic neuropathy, and floppy eyelid syndrome. Patients with these conditions have a higher incidence of keratoconus. If you are a resident or fellow who will be taking the OCAPs or the oral board exam sometimes in the near future, this is a good list of conditions for you to familiarize yourself with. I do believe they've had multiple choice questions in the past that asked about what other conditions keratoconus was associated with. So the histopathology of keratoconus, it causes fragmentation of Bowman's layer. It can cause thinning of the stroma, as well as folds or breaks in Descemet's membrane that equate to clinical hydrops, and it can cause diffuse scarring. So you see scarring between the fibrils of the stroma, all these unusual cells that shouldn't be there. The clinical features of keratoconus, you may see red reflex scissoring if you're looking with a retinoscope or a direct ophthalmoscope. You can look for Rizzuti sign, so that's when you shine a pen light on the patient temporally, and you can see that conical reflection of light from that cone-shaped cornea nasally. You can see a Fleischer ring, which is iron deposits in epithelium around the base of the cone. Basically, iron deposits in the cornea tell you where there's areas of drying and tear film abnormality, so you can see that around that base of the cone. You can look for Vogt's striae. These are parallel stress lines in the stroma. And you can look for Munson's sign, which is distortion of the lower eyelid when the patient looks down. That cone literally indents their lower eyelid. That can be seen in very advanced disease. Keratoconus can lead to acute hydrops, which is tears in Descemet's membrane. It can result in sudden corneal edema and the condition tends to usually heal spontaneously in about 6 to 12 weeks, but it does leave a corneal scar that often can be quite visually disabling. So when we have a patient who comes into our practice and they're a keratoconus suspect, or we're thinking about keratoconus, what are the things we want to be sure to check? Obviously, we want to get a baseline refraction. We're looking for a patient who's generally a myope, a high myope, and we're looking for a patient with lots of astigmatism. We'll get a corneal topography. We'll be looking for steep keratometry readings. So this is not the patient who has K readings of 41, 42. This is the patient who has K readings of 47, 49, 50. The patient will have a lot of astigmatism, so there'll be a big difference between their flat and their steep K reading. And one of my favorite ways to evaluate keratoconus patients is to look at the placido disc view of that corneal topography.